Hi, my name is Sam Schiffman, and today I'm going to talk to you about how standards for AI will revolutionize healthcare. But first, I want to introduce you to my father. He's in his mid 70s and lives in Texas. And yes, he does play the banjo. But recently, my mother's been complaining about him being forgetful and disoriented. Now, he's always been a little forgetful. So it's hard to tell, is this something new that I need to make sure he gets medical care about? Or is this just a continuation of his normal behavior? Now, my parents are just two examples of the aging population in this country. Did you know that in 2034, we're going to have more people over 65 than under 18 for the first time ever? At least that's according to the US Census Bureau. And Japan is already there. Many places in Europe are predicted to be going in the same direction. Now, older people have longer health records. They often see more specialists and generally require more care. This increase in demand is going to run smack dab into a decrease in supply. As we know that medical professionals are leaving by the droves. Some of this is because of retirement. Some of it's because of COVID, but some of it is just because of the rigors of working in modern healthcare. Now, whenever you have an increase in demand and decrease in supply like this, somebody gets squeezed. In this case, it's not just going to be the patients. It's also going to be you and I, as we help our aging loved ones navigate an ever more complicated healthcare system. At the same time, we still need to raise our own families, to build our own careers, and to live our lives. And statistics show us that we're generally doing that farther and farther away from our loved ones. For example, my parents who live in Texas, I live in Massachusetts. We're not the only ones who are going to suffer. Health plans are going to see an explosion in costs. This is a natural result of a supply and demand problem. But another aspect of it is that they aren't going to be able to hire enough nurses to do all of that care management. So they're going to need administrative staff to help form partnerships with their members and their loved ones in order to make sure that they control costs by getting the right preventative care. Because as health insurance companies know, $1 spent on preventative care today can save hundreds of dollars down the road. This partnership is part of the Internet of Health, a strong partnership between providers, health plans, loved ones, and patients based on data. And that data being shared responsibly. However, as I mentioned, many players in the Internet of Health are not medical professionals. This is where AI steps in. AI is going to help those non-medical professionals make sure that the patient gets the care they need at the right time. But that's only possible if that data is available in standard. Did you know that in the 1850s, to go from Buffalo to Cleveland, you had to change trains twice? With modern transportation problems, I'm sure you can imagine that in the 1850s just how difficult it was to get train schedules to line up that perfectly. It was so bad that it was actually a booming business in Erie for people who were stranded overnight on the trip. This was because people couldn't agree on the track width. Some companies thought it should be 6 feet. Some companies thought it should be 4 feet 10 inches. Still other companies already went with the standard that eventually grew of 4 feet 8 inches and a half. Now, before that standard came out, The problem was so bad that some places in the country were actually looking to build machines that would change the wheels on the train so that it could go from one track to another without taking all the passengers and all the luggage off. But luckily, eventually we agreed on a standard, and that standard means that today you can easily go from Buffalo to Cleveland. I see some of the same things happening in AI. We see these amazing solutions that can do all kinds of amazing things, like staging cancer. They're identifying all kinds of great data, but they're putting it out in a custom format for that single use case. And that data can't jump the tracks. However, if we put it into a standard, then that data can be used for many different purposes down the road. Because if there's one thing I think we can all agree on, we've only just started to understand the power of that data. If that data is available in standards, we can unlock it in the future to do amazing things. But what standard? Well, let me introduce you to HL7. HL7 is an international organization that shepherds standards in healthcare data. One of their standards is HL7 v2. Now, there was an HL7 v1, but nobody talks about v1. HL7 v2 came around in the 90s, and it was originally designed so that labs could report results to hospitals, and hospitals could communicate internally and externally. But generally, this was over modems. So this was the lab's computer would call the hospital's computer and send some messages over a phone line, so they had to be really, really small. But both sides knew who was calling and where they were calling, and as long as they understood what the structure was, everything was fine. So the structure of HL7 v2 is a little loose, and that makes it pretty bad for interoperability. So HL7 teamed up with a couple of different efforts and came up with HL7 CDA. Now, this is an XML standard, the most common of which is the continuation of care document, which is designed to capture everything that an EHR knows about a patient at the time of an encounter. Now, as you can imagine, that can get to be a pretty big XML document. And in today's modern mobile-first world, that doesn't work very well. So HL7 has taken the next step forward and introduced FHIR, which stands for Fast Healthcare Interoperable Resources. What they did was they took that large XML structure and broke it into small resources. So now an emergency room can request, say, the allergies and problems for a patient without, say, getting my tonsillectomy that I had when I was 5. They did some other cool things, like added an API to standardize the communication of these resources so that all the little FHIR servers all over can all talk to each other and ask questions in standard ways. And they built in extensibility, which is pretty cool because they recognize that no standard could, in fact, capture everything. So this makes it really good for interoperability, and it makes it mobile friendly. So what would AI results look like on FHIR? Well, as I look around, there are lots of amazing things that AI systems can do, and the internals of the AI system are amazing and magical. But what they result in tends to be pretty standard. For example, natural language processing does what's called named entity recognition. Named entity recognition is essentially finding entities in text and some attributes about those entities. Clinical inference is another example. Clinical inference is trying to infer missing data from the chart. So, for example, we see that the patient has been prescribed metformin and they have some high HbA1c tests. That probably means they have diabetes. So clinical inference is going to identify the entity of diabetes as possibly supposed to be in the chart. Now, as amazingly different as those two things are, they are resulting in more or less the same thing, an entity with attributes about it. So let's look at how that could play out. I want to introduce you to James. James is an auto mechanic, and unfortunately, about 4 years ago, he was involved in an explosion at his garage. He was rushed to the hospital with burns on his arms, but luckily was okay. When he got to the hospital, the doctor noticed that he had a MedAlert bracelet on. That MedAlert bracelet told her that he had malignant hypothermia. Malignant hypothermia is a severe reaction to anesthesia. Luckily, James didn't need anesthesia at that particular visit, but his doctor noticed that it wasn't coded anywhere in the chart. So she made a note that somebody should follow up on that. Unfortunately, they never did. And about a year ago, James was involved in a severe car accident, and he was rushed to the hospital where he was needed to be given anesthesia. Now, unfortunately, the burns on James' hands, the scars were irritated by his bracelet, so he'd stopped wearing his bracelet. So they had no way of knowing that he had this condition. They gave him anesthesia. He had a severe reaction, spent 3 months in the hospital and another month in recovery. Now, we can't blame the doctors for not reading every single note in James's record. But if they had had an NLP system available to them, then it could have found this. And what would it have found? It would have found an inferred entity. Pieces about this inferred entity is first and foremost the confidence level and the fact that it came from NLP. We want to be responsible with this data, and we want people to understand that it's probabilistic in nature. Doctors are making probabilistic decisions all the time. That is what a differential diagnosis is. As long as we make it clear that this data is another piece of probabilistic data that they can include in that calculation, then they can use the data. But if we try to make it a surety, then they have a good reason to be suspect of the data. What else? Well, we want to capture the fact that it's malignant hypothermia, right? So the value that we saw. We really need to capture some attributes about it. For example, here we're capturing assertion, which is it about James? Is it a negation saying that he doesn't have it? Or is it perhaps about a family member? It's great that some AI systems can also identify some of the standard codes and coding systems that might be associated with malignant hypothermia. And most importantly, we need to figure out what the entity type is. Now, as I've worked with multiple different AI and NLP solutions, this has been the one that I've struggled with the most. Not just every solution provider, but every model seems to have a different set of entity types. For example, this is one model's all the various different entity types that result in basically a condition. If we can standardize this list of entity types, then we can do things like create condition resources. Now we want to carry in the metadata of that resource the fact that it was inferred, right, in order to be responsible. And we only want to produce that condition resource in use cases where we have a tolerance for the fact that it came from an inferred source. However, by creating that condition resource, it can be utilized by any system designed today to understand FHIR. And as you can imagine, that could be a very, very powerful system in the future. Also, we want to understand relationships between entities, which is another thing that AI tends to be pretty good at doing. For example, you might have noticed that there was a date captured before. Well, if we can know that that entity is related to the malignant hypothermia, then we can enrich the condition resource when we create it with the date that it was found. So now we have this data in a standard. What's the potential? Well, if we look at what's available now in the structured record, there is a lot of stuff. But we all know that there's a lot of stuff that's not in the structured record. There's clinical notes, there's med sigs, there's free text that a doctor has entered. There's also a lot of data that's not in the record at all today. Let me introduce you to FA. FA recently flew from Buffalo to Cleveland, a short flight of 3 hours, right? But unfortunately, due to a problem at the airport, she was stuck on the tarmac for 10 hours in a middle seat between two other people. A couple days later, she went to the hospital complaining of pain. They asked her if she had been on a long trip. Now, FA didn't consider the trip from Buffalo to Cleveland to be very long, so she said no. Now, if the hospital had had access to an AI that could go and look at, say, FA's Facebook posts, it could have noticed that, in fact, she spent 13 hours in a confined space. This could have really affected the doctor in the sense that they could understand that there's a high probability that this could be a blood clot. But as it was, they did not make that diagnosis. AI gives us the possibility of unlocking all of that data and bringing it into the structured form that can help doctors make good choices. Let's go back to my father. There's a lot of evidence today that AI can detect mental decline just by looking at data about activity that can be captured in a standard smartwatch. So, if my father had a smartwatch and I had an AI system, it could help me understand that quantitative data in a qualitative way. Much like my mother telling me stories as a qualitative evidence about what's going on. Now, AI is never going to replace my mother, but it can help me interpret more data, which gives me more points of information to tell me whether I need to help my father get to a doctor soon. It helps make me an active part of the Internet of Health. What do I need from you? I need you to take a look at where you use data today. I need you to see where standards could be applied. Standards are only standards if people use them. HL7 can publish standards till they're blue in the face, but unless people adopt them, they do not become standards. But even more importantly than that, I need you to think about how you're going to become an active member of the Internet of Health. How are you going to make sure that your parents and your uncles and your aunts and your other loved ones are going to get the care that they need? What data do you need from providers? What data do you need from their health plans? How are you going to get that data and how are you going to interpret it? Get involved. Thank you.